So with no further ado, on behalf of Braille Institute, I am pleased to welcome Dr. David Granet. Thank you.
Oh gosh, Vicki, thank you. I'm already nervous that I can't live up to what that sounds like. You know, the title you left out is that I am a dad of 3 and a husband of 1, and married for 27 years. So those are the 2 titles I'm most proud of within that whole list. I know that the title of this talk is Pediatric Low Vision, but the title I told Vicki I was going to talk about was a little bit of this and a little bit of that. So I'm going to jump right in to make sure we have enough time for conversation afterwards when I wind down. I got a lot of stuff I'm going to try and throw at you, but I'm hopeful that what I'm able to do is make some things that may not have been clear and make sense out of the interaction with a physician and what the words that we say mean, not just what they sort of sound like they mean. So I'm going to try and see if I can share my screen. We're using Microsoft Teams, which I have never used before. So we practiced a little bit before, and I think I've got this.
There it is.
And with that, we are off. So that's the Children's Eye Institute, which is right next to the Adult Eye Institute and on the campus of the Shiley Eye Center, which is pretty amazing that we're all here in San Diego, and the sky does look like that. You know, it's always blue. I want to start you off with this quote from one of my professors in medical school, George Palade. He discovered the ribosome, which is in the news a little bit today because the vaccines that we have with mRNA are translated by the ribosome into a protein. So that's part of how this all works. George discovered this in the late 1950s, 60s with an electron microscope. And the first day of medical school, he told us, we are 100% certain that half of what we teach you will still be true in 2 years. We just don't know which half. And so I put that caveat out there as, you know, what I'm going to try and talk about, I'm certain, at least for now, is the best knowledge we have, but it's going to change. I don't know exactly which way it's going to change. I hope we get better. I hope we're always getting better. But I'm going to do the best we can to give you our best knowledge as it stands today. This is a great little story about Dr. Palade. He eventually came to San Diego and joined UC San Diego, and his wife is here still on faculty. He's since passed away. But I asked him, what was it like? I mean, oh my God, you won the Nobel Prize for this. And he just very humbly looked at me and said, David, at that time, we were the only people who had an electron microscope. So he was the first one to look and the first one to see it, but he was very humble about it. You know, he didn't talk about how he developed it and how he created it. So here are some of the doctors that I work with and the team that we have down here on the bottom left, as you're looking at it, is part of our team of the whole group here at the Eye Institute. Above that is a picture of us when we went on one of the missions that we did to try and help other kids. That was actually into Tijuana at the time. And here are the doctors. This is Dr. Movigar, who's first. Dr. Adele recently joined us. She's doing research right now on the structure of extraocular muscles. Me, I had hair when I first started. And then Dr. Robbins, who's been here for now almost 20 years. We do a whole bunch of research that we put together. We teach. We try and get better at what we do. We don't look at what we've learned as like grandma's cookie recipe where, you know, grandma did it that way and nobody wants to change the recipe. But so we still do it, you know, just because it was done that way 20 years ago, it doesn't mean we want to do better if we can't. So we're always trying to get better. And that's what the research is about. And we spend a lot of time teaching. You heard that I'm involved in global work with Ken Nischel, who's at the University of Pittsburgh Medical Center and the Children's Hospital there. He and I co-founded the World Society for Pediatric Ophthalmology and Strabismus, which is now the largest organization of its kind in the world for people who take care of kids and adults with strabismus. So it's it's really our goal and our pleasure to be able to teach doctors from around the world. And if you look at around the world, this is from the World Health Organization, retinopathy of prematurity is still the #1 cause of childhood blindness, along with congenital cataracts, glaucoma, and other hereditary retinal diseases. And if you look at the data, you can see the millions of people that are involved, and break it down by the different diseases and who has what. Corneal scarring is a big deal around here. Stuart Brown was the first chairman of the Eye Institute where I sit, was the first person to do a corneal transplant in a child to try and restore vision for things like Peter's anomaly. So we take it very seriously. It was considered heresy, by the way, at the time, and everybody thought that it was wrong what he was doing. But yet now that's the standard of care. If somebody can't see, is to give them a new cornea if you can. So, all this data exists about what's going on. But I think one of the things that I found most interesting is if we use the Atlanta disability definition of visual impairment, and that's the one that's standard, they use it as visual acuity of 20/70 or worse in the best seeing eye after you've been best corrected. If you look at that group of people, a third have isolated visual impairment, and 2/3 have other impairments and disabilities as well. So, and of those who have visual impairment, in which it was known why they had a visual impairment, about 2/3 had low vision, and 1/3 were worse than 2400, or legally, essentially blind or really disabled there. So, low vision versus very low vision. If you break it down. So 1/3 isolated visual impairment, where that's the only thing going on, and 2/3 with other things going on. That makes it very important to understand in context the role vision plays as we talk about the whole person who's trying to function in this world, which unfortunately wasn't built for people who don't have or who have some low vision. So it's important to think about the whole person. And around here, when I'm teaching our medical students, our residents, we don't say that someone is an albino. We say it's a person who has albinism, right? It's a person first. So we try and be careful about our language, because over the years, I think we've all learned language matters. And along those lines, we have to talk about what is vision. Vision is the ability to see visual stimuli. How do we measure vision? Now we start talking about the smallest letters that can be read. So we say somebody's got 20/40 vision. Well, I mean, that's black letters on a white background. Nobody lives in a world where it's just black letters on a white background. We have motion at the very least. We have different lighting settings. We have various different contrast settings. Black to white is the largest contrast, and we have color as well. So it's a funny definition of vision, because there are people who have color deficits, but their vision's impacted, but they still may be able to see quite well. My dad was significantly color deficit. He was a nuclear physicist and a nuclear engineer, really smart, and was able to see 20/20 despite his color deficits. So when we talk about vision, it's sort of this catch-all phrase that nobody exactly knows what it means, except that we measure it with black letters on a white background when you go to an eye doctor. And the Snellen chart, we'll talk about eye charts in a little while, but that was developed in the 1850s, and we still use it. So when someone goes to the eye doctor and tries to describe what their vision is or how they see, or I'm communicating with a teacher and somebody's acuity on an eye chart looks like it's 20/40, that's not necessarily to say that they see the same as someone who needs glasses, and that's the only thing wrong, sees 20/40. If they have optic nerve hypoplasia, for example, or there's visual field deficits, or they have nystagmus, it's not the same, even though the acuity sounds like it is. So I think that understanding what we mean when we say vision becomes really the touch point where we have to start. And then doctors that you see often actually are forgetting about vision and function. And the doctors are often thinking about the anatomy. And they're saying, okay, the eye is there, or is the retina normal, or is there a cataract, but not talking about what people see. And I think that's a failure of our medical system frequently, quite frankly, is that we forget that the whole goal of this is to talk about what the patient, the person in front of you, sees. So when we talk about, as doctors, what the requirements for vision are, is that vision starts with, from the very, very front, which is you need eyelids to open and close to protect the eye, and then to spread a tear film clearly over the front of the eye. Anybody who's got really bad dry eye knows how important that is. And then there are 3 layers to the tears, for heaven's sakes. So that has to function. Then you need to have a cornea, the front part of the eye. And we'll talk about that, what that all is in a minute. But behind the cornea, you have a fluid, and then a lens, and then you have to have the jelly of the eye, and then you have to have, everything has to be in focus, and then you have a retina, which is like a digital chip in a digital camera, and that has to collect light, and then it has to send it along a cable. We call it the optic nerve, and I'll show you all this in a minute. And then it has to go to the brain to interpret what you see. There's a lot of things that have to work for vision to be functioning, and a problem anywhere along the line will affect vision, and that becomes important. So when we're talking about what's going on with someone who presents in front of us and needs help or is not seeing right, there are 2 issues that we always have to ask. The first is, why did this happen? And then it is, can we help? Can we fix this in any way? Which sort of leaves us somewhere between Albert Einstein and Bob the Builder, right? The thinking part, the figuring out what's going on part, and then the what is there can we do? And sometimes there isn't anything that can be done. And that's we wish there were, and we work hard and do our research to get better, but at least knowing that's important. And to get there, I want to review some F.A.A.P with you. And I know you don't want to go to school on a Wednesday afternoon, and that's the last thing, but I got to do a little bit of that here. So let's dive right in, and we'll scatter some leaves as we go. There's a lot to the eye we'll talk about, but when you even talk about ophthalmologists, there are a whole bunch of different kinds of ophthalmologists, or people that take care of the eye. We have comprehensive ophthalmologists. The eye is 1 inch long, yet it's divided into all these specialties. There are people who are cornea specialists or retina specialists, or deal with glaucoma, which is a disease, not even a part of the eye, and they're just glaucoma specialists. There are neuro-ophthalmologists who deal with the way the brain and the eye interact. There are pediatric ophthalmologists who also typically are strabismologists, and between us, they're the smartest of the group. That's what I do. Then we have optometrists who haven't gone to medical school, but have studied the eye in a specialty program and are licensed doctors of optometry. We have ophthalmic techs and assistants. There are orthoptists, of which we have one here, Erica Acera, who are the shorthand for that, as we say, they're physical therapists for the eye. It's not quite the full story, but it's close. And they are a great help for people who deal with children and who deal with strabismus. So all these different categories, and depending upon what you have happening, you might encounter any one of them, and that's okay. But it's really helpful to have somebody who you identify as the captain of the team. And for kids, it's usually the pediatric ophthalmologist. So if you're interacting with a retina specialist or neuro-ophthalmologist, and you have a pediatric ophthalmologist, the information should flow back to that specialist, and that specialist should help you figure out how to put all this together, because it gets confusing as you go along. When we look at the eye, the picture on the left there is a typical picture of an eye. And the first structure that you have to deal with is their eyelashes, right? There are people who lose their eyelashes for all sorts of different reasons, and that can become a problem. You can get infections right at the eyelash and lid border called blepharitis. Then we hit not the eyeball, but we hit the tear film. And behind the tear film is going to be, we start to get to the structures of the eye. But so when we look at it, we see the eyelid, the pupil, the white part of the eye, even though it's labeled sclera, is not the sclera. there is a covering of the eye called the conjunctiva. And if you look at our other picture, the conjunctiva layers on top of the white part of the eye, folds over and underlies the eyelid. So as you blink, you have conjunctiva sliding along conjunctiva on the surface of the eye, which helps protect it. And there are all these little muscles that help move the eyelid up and down that you have to make sure they control. And then the eye has to work with the other eye. So these are the structures that we start to dive deep into when you look at it. When you talk about the colored part of the eye, that's called the iris. And my favorite thing is the pupil, because the pupil is just a hole. It actually is not a structure. And if you think about it, if you look at, I'm from New York, if you look at a bagel, we don't have a name for the middle, the hole in the bagel. It's called the hole. Or the hole in the middle of a lifesaver is called the hole. But the hole in the middle of the iris is called the pupil. And it's called the pupil. The word pupil means little doll. It's the same reason why we call children in school pupils, little dolls. And if you get close to somebody and you can see your own reflection, it looks like right in the pupil, there's a little doll. It's you reflected. And that's where the word comes from. That hole allows light to go into the eye. The bigger the hole, the more light. The smaller the hole, the less the light. So somebody who doesn't have an iris, called aniridia, no iris, they have a large opening there, and light is they're really sensitive to light because they don't have the ability to make that opening small. So once you start to understand what goes wrong or it's not working properly, then the symptoms or the problems that a person faces start to become more clear. So if we start looking at the structure of the eye now in cross section, there we have the cornea. Then there's the conjunctiva and the sclera is the white part. That sclera is made of the same material that the cornea is made of, but it's organized differently. The fibers are organized haphazardly in the sclera and organized very, very carefully in the cornea, which makes it clear. You can imagine then if you disrupt the fibers of the cornea, it turns white like the sclera, or it becomes opacified. And so anything that causes damage to the cornea becomes white. So as doctors, if the clear part of the eye starts to become white, we know there's been a problem. And that's why sometimes children are born with that clear part being white, because the structure was never formed correctly. Behind that is the anterior chamber. It's filled with a clear fluid we call the aqueous humor, and it provides the eye with its life-giving nutrients and oxygen. In the rest of the body, life-giving nutrients and oxygen are provided by blood. Here, if you had blood, you couldn't see. So whoever designed us, and I believe in the miracle of the body, they designed us to have a different liquid to allow us to be able to function and keep the eye alive, and that liquid is aqueous humor. Then we have the colored part of the eye, the iris, which decides how big or small the pupil will be, that allows light into the eye, and has pigment associated with it that helps block any extra light from coming into the eye. You can imagine if you didn't have that pigment, you'd get too much light, and that would be a person with albinism who doesn't have the pigment there, and they have too much light coming into the eye. Then we have the lens behind the eye with little muscles that can change, by squeezing the lens, can change its shape and allow you to focus. Then you have a jelly, and on the back wall of the eye, the retina, which allows you to turn light into a biochemical electrical signal. And that signal then is sent along the optic nerve, which is about the size of a pencil, for example, in thickness, and back to the brain. And you need that brain to see. So that's how come we see. And all of that has to go right for you to see. We also have a little drainage system, which is fascinating. We make tears, but they have to go somewhere when they've done lubricating the eye, and fresh tears come. We have tiny little tubes that drain away those tears in the corner of your eyelids, down into the nose, along the lacrimal sac. That's why when you cry, you have to blow your nose, because it drains right into there. If that gets blocked, it can cause some problems, but generally it doesn't interfere with vision. So I'm going to tackle a couple of problems so that hopefully they make sense. We were looking at the retina before. This is what a doctor might see when they look at a retina. And right there is the optic nerve, and there are red lines coming out of it. Those are the arteries and veins that then supply the blood for the retina. They are behind or in the retina, not getting in the way of vision. Sometimes if you close your eyes, you can see a reflection of those lines. That's because they block vision a little bit with blood in them. And that optic nerve is about the size of a pencil. And if that's a pencil, right now you're looking at the eraser end of it on end. So it's really 1.5 millimeters. So that part of it's smaller than the pencil size that I was talking about, but it gives you a sense of it in size. And here we have, in the other picture, we have a tiny little nerve. It's just that little part there, and it's much smaller. That nerve has less tissue, and that hypo means less, plasia means tissue. Therefore, you have optic nerve hypoplasia, less tissue. And that would be one of the reasons why the eye could be otherwise normal, but now the information doesn't get back to the brain. What else does the brain do? The brain helps control the movements of the eye. We have 6 muscles attached to the eyeball that move it up and down, side to side, and spin it. And the other eye also has 6 muscles. They have to work together. So it's a very complicated system. And if they're off even just a little bit, you can get double vision and from that misalignment because the 2 eyes are looking at different places, which means that you end up with misalignment of the eyes, or what we call strabismus. And doctors will use either prisms or other techniques or even surgery, which I was doing this morning, and cut muscles and move them in different ways. And these are the muscles attached to the eye to align the eye. And that's what the strabismus surgeon does. And, so here again is a normal appearing optic nerve and retina. The darker area is the macula. The leading cause of irreversible blindness in the older population is macular degeneration. And that's the area that goes, that's the part of the eye. And you can see there are no blood vessels right there. That gives you your best vision. So that's an important part of the eye, and we like to make sure that that's not damaged. Sometimes there are inherited diseases, Leber's congenital amaurosis, for example, that would damage that area of the eye, or there are infections like toxoplasmosis that like to damage that part of the eye. A coloboma, which means absence of tissue, might involve that part of the eye or even the optic nerve. Colobomas are always at the bottom of the eye and extend up because the eye develops from the top and around to the bottom. And so therefore you end up with a defect here if those parts of the tissue don't come together. We call it a keyhole defect. And if it involves the macula, vision can be quite poor, but if it doesn't involve the macula, vision can be quite good. This is the retina of a baby that was born too early or prematurely. So this is retinopathy of prematurity. And out here on the edges, the retina never fully developed, and it's actually turned and being pulled towards us as the observer. And that can actually peel the retina off and cause permanent loss of vision. You can see these blood vessels don't have that smooth development that you saw in the normal eye, but are rather serpentine because of the changes that have taken place. Here, Dr. Robbins, every week, goes to the neonatal intensive care unit and examines the babies so that we can either use laser or injections nowadays that can also be used to help prevent this from happening. So without fail, every week she's there, and if she's out of town, somebody else takes a look to watch these children. We're involved in helping set up screening programs for neonatal intensive care units around the world. And I'll give you an example. One of the doctors that we trained that came here was from Alexandria, not Virginia, but Egypt. And there was no one examining the babies until he got back there. So it's a big deal to make sure someone looks, because there is treatment that we can do. And that's my son when he was in the neonatal intensive care unit grabbing my finger. A picture that I'll never forget. Helping those babies when they're completely helpless is one of the greatest things that we get a chance to do, because they can't help themselves. They count on us. And I get choked up. He's 13 now and doing great, but I get choked up when I see that. So, doctors don't get a free pass. We have to deal with life also. That is an important picture, although it looks like an eye. It's not the eye. It's a picture of Mars. But you can see how you can get lost sometimes looking at some of these pictures. I just want everybody to know, don't worry about that. We all do. So there are other diseases. I showed you what a normal retina looks like. If the pigment that's there to absorb light clumps, we call that retinitis pigmentosa. The pigment's clumping, and it clumps into various different areas, and now the retina doesn't function as well because this pigment is missing. Some of you have seen this device that we use. It's called the slit lamp biomicroscope. It really hasn't changed very much in, like 100 years almost. It is a brilliant device that allows us to look at the eye closely, and by projecting a small beam of light, it's like an optical knife. It allows us to see structures of the eye in relief. This is one of my patients who, let me take the picture, who has albinism. And this is me looking through the microscope and doing full illumination. And if you look closely, there's a circle there that you're seeing right through the iris because there's no pigment, and that's the lens of the eye that we can see. You can imagine with that much light going to the eye that this person will be sensitive to light or photophobic and want to wear sunglasses a lot, even inside. And so we have to work with the school to make sure that the school understands that this is a person that has to wear sunglasses, and that in a bright light setting, we want to be putting them in a situation where they don't have to have glare. So working with the school system becomes really important in understanding what accommodations are valuable to that person. And it's important also to remember that accommodations do not give someone an unfair advantage. And I have patients of mine, children who don't want to ask for anything. They don't want to be singled out as, oh my God, I'm different. Or that their friends say, oh, look, you got an advantage. You have extra time to take the test. You know what? If they think it's an advantage, let them trade eyes with you, right? They can have your eyes and the advantages, and you take their eyes, and we'll call it even. If that's really supposed to be the big advantage, please. It just levels the playing field. It just makes it fair. Fair is not everyone getting the same thing. Fair is each person getting what they need. And some people need different things. And trust me, everybody needs something. So for some people, it's a little more obvious than others, but everybody needs something. And some people need glasses. Here's a baby that needs glasses. And through the tests that we do in the office, we can tell whether or not a child needs glasses by reflecting light off the back of the eye after we put drops in the eye. And that light tells us whether or not the eye is too short, too long, or shaped in a different way. And that leads us to nearsightedness and farsightedness, words that we use so easily, but not everybody knows what they mean. In nearsightedness, it means that the focal point of the eye, where light is being focused, lands before the retina. Because of that, you can think of the eye as being too long or too big for the focus. So we put a lens on in front of the eye that allows the light to be pushed back and moves the focal point onto the retina. And that's nearsight. That's myopia. It allows people, because when an object's closer, it pushes the image back. It allows people to see up close better than far away. That's why it's called nearsightedness. Hyperopia, sometimes called farsightedness, is when the focal point of the eye would be behind the retina, or the eye is smaller than the focal point, than the optics of the eye. An example of that's a baby. Almost every baby is born farsighted because their eyes are smaller. And we're going to go through that in just a moment. And so we put a lens in front of that person, and it allows them to be able to see clearly. Interestingly, the lens inside of our eye, because it tries to help us focus when things are brought up close. Everybody who's old enough knows that it gets harder and harder as you get older. Can focus for farsightedness, but not for nearsightedness. So some people who have farsightedness will try to focus for themselves, but because their brains think they're trying to look up close, it drives their eyes in together to look at the near object, and it makes them look cross-eyed. It's called accommodative esotropia, or focus crossing. And those are the kids that we put glasses on and can straighten out their eyes. So that can really help, knowing that. And then we have astigmatism, which means that the eye is not perfectly round in all directions. In fact, it's shaped more like a football than a basketball. And as such, we need special lenses, astigmatic or cylindrical lenses, to correct that. And that usually stays pretty stable throughout someone's life. Another word that you might hear is anisometropia, or anisometropia means unequal power. An means not, iso means equal, metropia means power. And that's when the right eye and the left eye have different powers. And you can imagine if that happens, you like one eye better than the other, you might start to ignore one eye. So let me take you through development as we go along. Babies are not born with normal sized eyes. They're about 2/3 the size of an adult. The optic nerve is not ready to function. So the fovea is not completely developed either when you're born. The color of your eyes is still changing until about 6 months of life. And your brain is still developing with vision. So it's not a surprise that babies are developing vision after they're born. And you'll see that if you look at babies at birth and in full term, we don't expect them to be great at using their eyes. They don't fixate well. They don't follow things well. They may even look like their eyes are misaligned. By 1 month of age, they begin to follow pretty well side to side, and their alignment gets better. And their acuity now is about 2300. By 2 months of age, babies are following vertically as well as horizontally, and their visual acuity breaks through the 2200 barrier. By 3 months, their alignment's good. They look side to side well. They can start to focus. That's accommodation. Binocularity is detectable. And by now, they're starting to have good social smiling and interacting with you because they can see your face and really have fun with what they're seeing. By 6 months of age, their coordination with their hands may not be so good, but their vision's actually good enough to pass a driver's test, and their binocularity is quite good. So let's just review that development pretty quickly again. At 1 month, you're asking, is your baby able to follow you with their eyes? By 2 months, does the baby look at you? At 3 months, does the baby look around, interact, and smile? And by 9 months of age, do they really seem to have their eyes straight? But I can tell you at 3 or 4 months of age, if your babies are constantly always crossing their eyes, that's something that you want to talk to your doctor about to get checked, because they can be checked. So it gives you a little bit of an idea of the development of the eyes. And what you can ask as a parent. As a doctor, we're looking for these things called red reflexes. If you've taken good photographs, you sometimes will see these red reflexes. Newer cameras get rid of them, but that's the light bouncing off the retina back to you, and you can see those. If the red reflex does not look normal, like in these children, they had tumors in their eyes, then it's a sign that we worry about. Now, if the child's not looking at the camera, you can get this effect in a normal child with nothing else wrong, who has nothing else going on. So what you're looking for is this kind of the asymmetric reflex that's always happening, not in just one picture, but you see it all the time. That's the giveaway to maybe talk to your doctor about it. And here's a whole bunch of different pictures. And this comes from the American Academy of Pediatrics See Red card that we use to teach pediatricians. I'm one of the past chairmen of the section of ophthalmology in the American Academy of Pediatrics to teach pediatricians. And Dr. Robbins and I wrote and edited their textbook on ophthalmology for pediatricians, where we teach them these kinds of things so they can learn to identify problems in kids. And I'll show them a picture like this, where the one eye looks very different than the other, and they'll say, oh yes, something has to be done about that other eye. So we're looking at all these different responses of the child to give us an idea of whether or not they can see. And we will play with lights and toys to get that feeling. I think a video is worth 1,000 words. So I want to show you a video of a child with what looks like normal responses in our office, with following the object. This is with Erica, our orthoptist, and she's got a toy in her hand, and he's 3 months old. And ooh, look, what's that? And his eyes get big, and he follows where it goes. Now we're spinning an object, and look, he's reaching for it. He wants to try and touch it himself. So it's the child that's engaged with you. It looks very different than this child who the parents have given us permission to show this video, who is 6 months old and does not see. And there's a very interesting, bright, sparkly toy, and the child is not looking at it, will not follow it, does not see it, does not track it, does not get all excited, not trying to look at it. Right? This I always get a little bit sad when I see this at first. because I know we're gonna have to talk about it. There's the drum spinning, nothing, and then the bright light right in the eye, no reaction. I did that to anybody who has somewhat normal vision. They pull away. The baby doesn't see it. So we look at that visual behavior to see the difference in the kids. And by 8 to 10 years, usually we have treated most of the things that we want to, because if we can, that's when they're most treatable, and the sensitive period for amblyopia, which is a word that we should talk about. But other visual functions, color vision is present by about 3 months of age, and the visual field around you by about 1 year. So you saw a little bit of our exam techniques. One of the things that we do is we hold a toy up, and if the child gets mad when we cover one eye and is happy when we cover the other eye, we're guessing they don't like that eye that they're upset with. Not every child so comfortably cries when they do this, and I apologize if anybody doesn't like this next picture, but some children find a whole other way to let us know that they don't like having one of their eyes covered, and kids are very, very clear about things sometimes. So there's that spinning drum called an OKN drum, and it elicits a response from you when you see something black and white spinning. It makes your eyes jump. And if we don't see that, we know there's a problem with the visual system. It usually estimates a vision of about 2200 or 2400. So it's a low vision test. We also can try and put numbers on a child's eye by using these televisual acuity cards. They have black and white stripes on one side and gray on the other. And the gradings get smaller and smaller. Those black and white stripes get smaller and smaller until a child can't tell the difference. And somebody holds up the cards, often it's Erica in our office, looks through a little hole. They don't know where the stripes are. And based upon the child's vision response, they look and see, did the child get it right? And when it's clear the child no longer can tell which side has the stripes, that's the limit of vision. There's a way to do the similar thing using electrodes on the skull that tell us when someone can see, called visual evoked potential. When kids get old enough, we can ask them to read an eye chart. These are my favorites, called Allen Kindergarten pictures. If Jurassic Park has been out, kids called that thing first one a dinosaur. This is McDonald's French fries. This one looks like a turkey, and this one of a telephone. Kids in San Diego have no idea what that is anymore. No one knows, because telephones don't look like that. There are all sorts of different kinds of kid charts that are out there. Erica and some people had the idea of putting together this one with symbols and ideas that kids would really recognize from their life and be able to tell us what they are. We haven't done that or proved that it works, but it would be a fun one to have. Dr. Robbins and I have written an article where we go over how to test vision in children to teach pediatricians and other ophthalmologists about this. There's something called stereo acuity, or 3D vision. When the two eyes work together, you get depth, where it shows you how far away things are. Big objects, you only need one eye to see depth. We developed the first photo screener, digital photo screener, that allowed people to take a picture of a child and know whether or not there was a problem. And in that, you get this red reflex, and you can see by the picture whether or not there's something wrong. And we developed a software that can analyze those images to tell you whether or not there was a problem. So these words that we've used, vision, binocularity, stereo acuity, color vision, peripheral awareness, hopefully they make a little bit of sense to you now. And when you talk to a doctor, they make it sense. One thing I did want to talk about is the 2040 or 2020 type of vision. And that is, what does that mean? It means at 20 feet, you can see size 20 type. And that's a 20 over 20. If at 20 feet you see size 40 type, or size 20, at 20 feet you see size 400, it tells you. And that's where those numbers come from. In England, they use 6'6", or at 6 meters, you can see a certain size object. I want to hit on amblyopia because it's an important topic. And that's when, if you're not using the eye, you don't see well. That was the technical definition. But really, sometimes the eye can look totally normal, yet the person still doesn't see. And that is, if you don't use that eye for whatever reason, you can imagine if there's an opacity, a cataract, corneal opacity. If it's not corrected early, your brain never gets the ability to use that eye. It's like people trying to learn a second language when they're 50. It's hard, but when you're 5, it's easy. So there's a a real critical period of time when if you don't learn how to use the eye, you never will. And Hubble and Wiesel did that work in the 1950s, and they won the only Nobel Prize for visual science for that work. So it's a big deal. On the National Eye Institute website, they have this great one-page article that just came out last week on amblyopia that for a handout to give that we'll be using now. And if anybody wants to download it, it's a great little article. So those cortical connections with the brain become important, that window for diagnosis. And that's why it's so important for us to get to children early. And anything that blocks the vision, like corneal opacities or cataracts, can cause that problem. Misalignment of the eye. You use one eye and you don't use the other eye. That other eye actually doesn't develop vision. I operated on somebody today who was an adult who developed amblyopia and was not treated as a child many years ago. He doesn't see well out of one eye. I can straighten the eyes, but I can't make that person see. If you have a lid that's droopy, it's blocking the eye, that has to be taken care of as a baby. Otherwise, that vision won't see. Same thing with hemangiomas for the same reason. So amblyopia affects not just black and white vision, but all the things about vision, all the stuff we talked about earlier on. And the treatment is still a patch. And I say still because if you go back to the Arabic literature from 2,000 years ago, and I don't read Arabic, but I had somebody else translate it, and it's been published in a book, not by me, but by someone else. And it said strabismus should be treated by patching the seeing eye. That's from 2,000 years ago. So that patch still works. It's one of the best pieces of advanced knowledge in medicine that we've had for so long. This is sent to me by a friend from the Middle East, and we don't do that in the United States, but that's a heck of a way to patch. I guess for kids taking off a patch, that's one way, but I don't like that. We have better ways to do that. We can put a drop in the eye, which causes blurriness. And we know that for most kids, that works about as well as a patch. So it's nice to have more than one tool. The key is to figure out which works best for the child. Now, I used a word earlier, strabismus, about the alignment of the eye. Here's a kid who came to see me. Are the eyes aligned or not? Well, at first glance, it looks like that eye's crossed, but in fact, when we shine a bright light, we can see with that little light reflex on both eyes, the eye's straight. And that's called pseudostrabismus. True strabismus, the eye is really crossed. And that's one of the things that we do. But half the time when pediatricians send us a child for strabismus, it turns out not to be. But the parents are worried, so it's worthwhile to come to us and check. If you pull, you can see in the top picture, that's a wide nasal bridge. If you pull that in, it's the same child. The eyes look much more balanced. This person looks cross-eyed. So if you look at a picture, oh no, it's cross-eyed. Actually, no. He's one of the world's great ping pong players. He's just looking at an object close to him. So don't get fooled in a picture. If you don't know what someone's looking at, then you can't tell whether or not they're cross-eyed. This child looks really cross-eyed. His parents actually brought him to the eye doctor to find out whether or not this eye was turned in. His mom, who's a professor of education, thought this eye was turned in. And his dad, who was a nuclear physicist, that's a giveaway because I mentioned that earlier, somebody who's a nuclear physicist, thought that this eye was turned because the light reflex was off. That's me. When I was a kid, my parents brought me to the doctor because they were worried, and my eyes are fine. But I was looking over to the side. Probably I was looking at my mom over to the side of the photographer while she was making a face to get me to smile. And there's my son, where it looks like maybe his eyes aren't quite straight. This was at J.C. Penney's having his picture taken, and he was not looking right at the photographer. Same thing can happen when you don't look right at the picture. So getting to a child early matters. And we developed a screening program here based upon work from the American Academy of Pediatrics that we helped devise, and it's published. It's how to screen and look for the basic things in children. And we have a protocol that we use, and it depends upon the age of the child, looking at different things, screening. Pediatricians look first at the kids when they're babies. And if there's a problem, they get them to us. When they get older, you can do screening with photo screening, having a kid read the eye chart. And we send a van around and we screen children all over San Diego, about 20,000 kids a year, trying to identify problems early that we've been doing for almost 20 years now. And we're getting close to, I think, 500,000 kids that we've screened. And if they have a problem, we get them care inside the van. We have an optometrist that can take care of them. If it goes further than that, Dr. Robbins and I and Dr. Movigar and Dr. Riddell will see the children here. If they don't have any health care insurance, we take care of them for free. One of the last things I want to talk about is nystagmus. Nystagmus is wiggling of the eyes, and there's a whole bunch of different ways to measure that. Most of the work that we know about has been done by Rich Hurdle and Lou Deloso. Rich and I worked together at the University of Pennsylvania, Children's Hospital in Philadelphia, and built a nystagmus laboratory there. Lou Deloso, in the middle picture here, has nystagmus himself. Lou's a good friend. His birthday is the same as my son's. And their research has led to newer surgery that can slow down the wiggling of the eyes, which is really exciting. And we've been doing that surgery for many years here. Nothing can stop nystagmus, but we can slow it down and we can help straighten the eyes out at the same time. Rich has been working on a new project that we'll be a part of that's doing some work outside the United States right now. Is the first study with a drop that can slow down nystagmus, which is really exciting. When it comes to the United States, don't worry, we'll have it. But nystagmus really is the way the brain communicates with the eye. And so anything that disrupts that can cause nystagmus. And the last thing I'm going to talk about is how you get drops in a kid's eye. This is how they feel. Oops, that's the older brother to that baby I showed you. This is how dads get drops in the kids' eyes. Just, put it into a water. I've been dying to do this, to get a water gun that you can put a cartridge with the medicine in it and squirt into kids' eyes, but companies don't really want to make that. Here's my rules. Less times per day is better when you can. Warming some drops up work. Cooling most drops up work is better. And only the first drop is your free shot. Every child knows what you're coming for in the second drop. Lay the baby or a child down in your lap. Put a drop with them flat in your lap in the corner of each eye, and let them blink whenever they're ready, and the drop will roll in. Nobody wants to have their eyelids peeled open. That's no fun. And I think it's important to remember that there's an educational and emotional impact to eye problems, and a physician needs to make sure that they're addressing those and talking about those, and helping anybody who's dealing with this, with the school system, working with the San Diego County Office of Education that we do here, making recommendations, getting people to the Hope Infant Support Program here in San Diego. They're spectacular. I've worked with Merrill Burke there for I don't even know how long anymore. And it's one of the most effective things that we can do is get a teacher for the visually impaired to help a parent raise a child with visual impairments, because no one knows. The books aren't really that good about that. And it's not something everyone's born with knowing. And your Aunt Sophie doesn't know how to do that because she hasn't done it. So you need that help and support. And there's a whole toolbox of stuff. Up there on the right is Leah Haivarinen from Finland, who's now 80 years old and developed the Leah charts. But she, on her website, there's a whole great series of videos that will help parents understand what's going on with their children and give some tips on how to help a child who doesn't see well. And then the very last thing I want to talk about, especially in this era of Zoom, look at us, or I guess Microsoft Teams, is screens. It's not good to look at a screen all day long, and it's a truism, and we're doing it all day anyway nowadays. But the rule of thumb is the 20-20-20 rule. Every 20 minutes, look at least 20 feet away for at least 20 seconds. And I tell people, look out the window, relax your eyes, take a break. Try not to look at blue light too late in the day, because that's not good for your sleep cycle. No applause necessary. I know that everybody feels like they need to be excused, their brains are full. So I'm going to tie up with these, with this quote, and that is from John Wooden, who I think is the greatest coach of all time. He's the coach of the UCLA basketball team that was considered one of the best teams in history. And he said, you can't live a perfect day without doing something for someone who will never be able to repay you. See, money is not the issue. It's the ability and the privilege of helping others, especially children who you impact their lives. And they're not going to repay you, and families aren't going to repay you. There is no repayment for that except knowing that you had a chance to live your perfect day. And so with that, I'll skip this last story because I want to tie up and give everybody a chance to ask questions. Thank you so much for your attention. stay safe, stay strong, and stay healthy. So thank you to the Braille Institute in San Diego here for the opportunity to chat with everyone. And I'm happy to entertain questions. I think I am now back with everybody.
Yay!
Vicki, thank you.
Oh. That was incredible.
A little bit of this, a little bit of that, you know. I know it's a lot, but hopefully everybody got something out of that.
Dr. Granet, thank you very much. Thank you for your words, for a very thorough and extremely informative and also a very, very inspiring presentation. To all, good afternoon. My name is Bradley Day. I'm one of the Braille Institute instructors. I head the youth programs at our San Diego Center. On behalf of all who attended, to you, Dr. Granet, we extend our warmest gratitude for your presentation. And we're also grateful to Wanda and to Vicki for helping organize this seminar. Dr. Granet, would you say you have about 15 minutes for questions?
You bet. I blocked out the time for everybody. I'm happy to answer questions.
Thank you very much. Very well then. For now then, to everybody here, we'll now take time for questions. In order to be considerate and respectful for others, please keep questions brief and allow time for Dr. Granet to reply and for other questions to be taken. Questions will continue then for about 15 minutes, and Vicki then will close our seminar with some parting information. For those who are joining by video, we encourage you to utilize the raise hand feature, which is found near the mute button. Please remember, in order to unmute, you will either select that mute button if you are joining online with the internet, or if you're joining by phone, to unmute by pressing *6 on the dial. So I see we have a couple of hands already raised, and I'll turn it over to Nikki Blackburn first.
Hi, I'm a teacher for the visually impaired in San Bernardino City Unified. Dr. Granet, thank you so much for the great information. I'm curious about the visually evoked potential. I like the visually evoked potential, and sometimes I'll have doctors say that it's not necessary. I often go to the doctor with my students, and I'll have doctors say it's not necessary, or we don't have the need for it for this particular student. But I'm always wondering why they're giving me that response. It seems like for students who are nonverbal, the VEP is a really great tool. But tell me if you know anything that I'm missing.
Hi, Nikki. First off, thank you for your question, and more importantly, thank you for what you're doing for children. You raise an important point, and it's a good one. I don't really have a good answer for you. Not everybody has the Sweep VEP available to them, and there's a little bit of old school sort of playing with people and trying to guess what they see. I don't know that that's that is really the best answer when you have an alternative. I think that for someone who's nonverbal, the other question might be, would they cooperate with a VEP? Because you do have to pay attention. It's based upon paying attention and looking at an object. Otherwise, if you're looking around, the visual evoked potential, which is part of the EEG, is not what you think it is because they're looking at something else. So there's a cooperation issue in doing a VEP that also, so you need to, like everything else, you need to pick the right tool in the right setting to make sure that you've implemented it. The other question would be, how will that information change what you do? So if knowing some different information means that you would do something different, then I would pursue it. If knowing that information is of curiosity, we're all curious about lots of stuff, and I like knowing as well, then you have to decide whether it's worth it to put the effort in or put someone through testing. There are tons of tests, and doctors are taught not just to do a test because you can, but because the test will give you information that will help make the person's life better that you're trying to help. So I hope that makes sense.
Yeah, I really appreciate that distinction. Will the results change what you're doing with the child is a great distinction. And it's my understanding they need to be able to attend to a screen for about 20 seconds at a time.
Yeah.
Is about what you say?
Yeah, and it's not just that they are able to, but that they will. I mean, you know, there's a child.
Distinction,
A
yes.
child we just saw recently that I was working with Don Cacao, who's our oculoplastic specialist here, and when I saw them, you know, I'm a kid guy, and so I made sure that when the mom was feeding the child with a bottle, that I jumped in and was able to get a really good look at the kid, who was totally happy. I call it bottle anesthesia. The kid had eaten already when he went to see Dr. Cacao and was unhappy, so he didn't get a good exam. So, you know, the ability to do it and actually doing it are two different things. And if anybody knows how to know what a 1-year-old is going to do, let me know, because I don't always know what's. I mean, you know, you do the best you can, and you have your go-to gimmicks and toys and fun stuff that you do. I mean, I have toys everywhere I turn. You know, here's Woody. You know, I always have something around. You know, I'm a terrible singer, but I'll sing. I'll do whatever it takes to try and get attention. So 20 seconds doesn't sound long, but getting someone to be still and look at what you want them to look at for 20 seconds is harder than it seems sometimes.
Yeah. Okay. Thank you very much. That was a very valuable answer, and I appreciate your time.
Yeah, and Nikki, I'm gonna very strongly suggest that you keep asking questions and that you keep raising issues when you go with I can't believe you go with the families to the doctor. I think that's awesome. And that you keep raising those issues and being their advocate, because over the course of a busy day, sometimes the physician will not pause, and they need to. And, you know, I'll run late in my office and people give me that look like, I can't believe you made me wait. But what do you do? I mean, somebody's, you know, in their office talking about their child. I'm not running out. I'm going to make sure I answer those questions. And you can see I like to talk. So you know, that's our job. And if they need to reschedule the appointment at the end of the day and make it the last appointment so they can sit and talk to you, so be it. Nowadays, you can do a video visit.
Thank you very much for that. Great question and great follow-up there. We'll turn the time to Marcia.
Okay. No. Okay, now can you hear me? Can you hear me now? Okay. I want to know about red light and the effect on either children, adults, actually even on dogs. And everybody's doing that red light therapy now, but it's like this, it's not really hot light. It's just like you turn on these things that you go on your face, and it does for others reasons, but I want to know if it damages eyes more. That's what I'm trying to find out.
I understand what you're saying. There are people who are using red light for joint pain. They're using it for skin. Low-level red light appears to have an effect on blood vessels and even on healing in some parts of the body. There is research going on looking at its effect on the retina as a positive treatment.
Okay.
But, you know, that's also because we don't really know. So any device that comes with a red light ought to have special glasses that come with it to protect the eyes right now. We just don't have enough information. And frankly, if especially in somebody who has a visual impairment, there's no way I'm doing something that would potentially risk vision in any sense. So that's where you put on the protective glasses. There are devices out there that I've seen that, as somebody who doesn't have a lot of hair, that you put on your head that helps folks grow hair, and they have all, like, you know, 200 LEDs or even low-level lasers that you put on to help grow hair, and that's where you have to wear the protective glasses, otherwise you can cause damage to your eyes. And obviously, you should not look at a laser directly, because that can absolutely damage your eye. And every year there's somebody who has that happen, and it's bad. We don't like that.
Macular Pucker as opposed to a macular degeneration.
Yeah, exactly. And so the low level red light is being looked at now, and it's so early that we really don't have an answer. So I don't want to in any way encourage anyone to do that. One other thing about red, which is really interesting, I mentioned people with albinism. There's a Corning 500 nanometer red lens that is supposed to be helpful for people with color deficits and people with albinism to see better and better contrast. 99% of the kids I take care of don't like it because, well, when they're old enough to talk about it, because it makes them look different. And so they usually get a neutral gray polarized lens to help prevent the glare. But that's the other use for red in ophthalmology.
Thank you, but I wanted to know the difference between macular pucker and macular degeneration or macular.
Oh, I'm sorry. I thought you were talking about the damage that can occur.
No,
So macular degeneration is
I know what that is, but I don't know what a macular pucker is. And if a kid's mom tells me this kid in your class has a macular pucker, the rest of the people think it's macular degeneration, but it must be something different, and they call it a different name.
Yeah, it is something different. It's so let's just for everybody else, in case not everybody understands this, macular degeneration we usually think of as a problem of the elderly, but when ophthalmologists talk about, we might say age-related macular degeneration to say this is the aging problem. That's basically the macula is getting older and the cells aren't functioning as well and they degenerate. But there is a form of macular degeneration and macular dystrophy that can occur in children as an inherited genetic problem. And we have teams of people here that are working on research from stem cells onward, from genetic transfer to try and help those kinds of inherited retinal diseases, which is a very exciting thing. We're not the only place doing it, obviously. RPE65 is the first disease that we had really a gene therapy transfer for, retinitis pigmentosa, where you could transfer a gene into the cells of the eye and make it function better, which is really amazing to me. That sounds like science fiction. And when I started my career, it was science fiction. The macular pucker is if you take the macula and you basically sort of cause a little pull on it and it comes up a little, that would be a macular pucker. So it's an anatomic change where it's almost like the macula has been pulled together or scarred that way. And it can cause damage. Anything that damages the macula will alter your vision.
Thank you. You were excellent. I like your humor. I liked everything. Thank you, thank you, thank you.
You're kind. Thank you very much. Thank you for your question.
Thank you. We have time for about one more question before we'll turn time to Vicky for some closing statements, and then from there we'll see where we can go. So we'll give the time to Andrea Lubin.
Hi, can you hear me?
Yes.
Is my mic? I can't tell if it's on my headset or not. Can you hear me well enough?
Yes. Yes.
Okay. So my question was about amblyopia. If you don't spot it, you know, what's the earliest or the latest that you can spot it and still try and help reverse the process or get them to use that eye?
So thank you for the question, Andrea. Is your name spelled R-I-A, not R-E-A?
Yes.
That's kind of cool. I like that.
Oh, thank you. Yeah, I normally go by Andy, actually, A-N-D-I.
All right. So, okay. Now you've given me two things to talk about because this is so great. One of the things that I've learned about with children, and I'm going to riff on this, and I promise I will get back to your amblyopia question.
Oh, yeah, of course.
That is that when I walk into the room, I try very hard to pay attention to the child and not the parents.
Mm-hmm.
And some parents get mad at me for that, but I can live with that. And I talk to the kid first because it's the fastest way to put a child off is to make them feel like they're ancillary to the whole process. This is about them. And so, you know, I come in and I say hi to the kids first. So if I saw your name, I would say, hi, is it like to be called Andy, Andrea, Drea? What do you like to be called, right? And I don't assume. And it is unbelievable how many times the parents and the child, I'm looking right at the kid and I'm talking to the child and the parents answer. And at the same time as the child does. So imagine like we're in the room and your parents go, oh, Andrea, at the same time you say Andy. And then, you know, right. And then I look over at the parents.
Especially when you're like at that age that you're like you're starting to really want the individualization. It's like, hey, I'm old enough now to talk for myself.
Exactly. And so then I'll ask I will ask the child, I'll say, Andy, I just had this really important question for you. And I go, what? I go, who are those people over there? You know, and I have the child do the introduction to their parents. And let's see, on the 19th of February, I'm giving a worldwide lecture to residents learning about ophthalmology, about examining a child. And this is how I'm going to be opening. This is what I'm going to be talking to them about, is recognizing the social interplay and what it's all about with a child. And the child will introduce me to the parents. I'll say hi, and then I'll turn back to the kid. So I've acknowledged them at least. And most parents get it by then that you know what I'm doing and why we're connecting to the child, because you cannot get an exam if you don't connect to the child, and you will not hear the important things you need to hear if you don't let the child talk. And the number of times I have had a parent look at me and go, "I didn't know that," after the child tells us something, and I'll say, "Well, that's what I wanted to hear from them." You know, it's their eyes. They're the person dealing with this. We need to listen to them and hear what they have to say. And so, you know, this conversation about your name has given me the opportunity to talk about one of my favorite things to talk about, and that is, you know, how to just be a human being, right? I mean, you wouldn't walk into a room and ignore the most important person in the room, and that's the person who's getting the exam or who we have to talk about. So it's really important to me, and it makes me sad when I hear about doctors not doing things like that and not getting it. And they take control. And you mentioned that they're old enough that they want to take control of their life, right? So this is where I say to the child, if you know, well, have you been wearing your patch? Are you wearing your glasses? Well, and I go, look, you want your parents to give you some autonomy, right? You argue with them about what your name is. Well, now you got to step up a little bit. You got to prove that you've earned this. Or they want contact lens. Prove you're responsible. Let's see, you know, and the contact lens truism, the rule of thumb is that girls become responsible roughly as they enter middle school around 11 or so. And boys don't become responsible until around 30, 31 years of age. And you know, you have to prove you're responsible, right? You want them to trust you, right? Do your homework, you know, clean your room, set the table, walk the dog. Let's show that you're responsible. Now you can get contact lenses. So by interacting with that child, I've developed this relationship where I can have that conversation on a real level. And I used to say to my wife, I think I'm the cool doctor. I think kids think I'm cool. And she's like, no, they think you're goofy. They buy that it's okay, that you're goofy. I can live with that. You know? So, all right, now I promised I would talk about amblyopia. So this is a really interesting question. When I was starting out, I was taught by the people who didn't have a lot of hair and gray hair like I am now, that you couldn't treat amblyopia after the age of 8. And that was first established and taught by a doctor named Marshall Parks in the 50s. And he passed that along. I got to know Dr. Parks. And at one meeting, I said to him, I go, how did you come up with 8? And he said, this is really true. People ask me for an answer and I have to give them some answer. So I say 8. I was so taken aback by that. Really? That's how this became in the textbooks? And what he said to me is, you know, you're in 3rd grade by the age of 8. It's really hard to ask a kid to go to school. It doesn't work that well at that point. And so his clinical acumen and his experience showed him that realistically by the age of 8, it was hard. And it turns out that that's more or less true, but not science. So the Pediatric Eye Disease Investigator Group, which is called PDIG, has done studies on this. And it turns out that up through the age of 18 or 19, you can get responses. And I say 18 or 19 only because that's what they studied. Yeah. Not because God sends a lightning bolt and fries your neurons. And suddenly
that optic nerve is cut.
That's it, right? It doesn't work that way. Yeah. So if you take a 14-year-old that's never been treated for amblyopia, and they have strabismic amblyopia or anisometropic, in other words, there's not an opacity there. It's just that the eye has not been corrected with glasses, or it's turned. Those people have about a 25% chance that they'll recover vision. I don't know which one of those are going to recover vision. So the age that they get to me is the youngest I will ever meet them. I can't go back in time. So I always feel like everybody deserves a shot at this. So why wouldn't I try? Why wouldn't I try on a 15-year-old? Well, if they won't do it, right? Yeah. I mean, the 15 won't do it is the reason why. Socially, it may not make sense. We patch often now 2 hours a day to start. 2 hours a day in a 15-year-old with 2400 vision in one eye is unlikely to work. You could try it. Why not? Let's try it. What have you lost wearing a patch at night while you're playing Madden on a football game or something like that? Super Bowl's coming up, so I'm thinking about that.
Yeah.
So it's worth a try, but it doesn't. The success isn't so good. But why not try it? And what you're talking about if you have 2400 vision is you're functionally one-eyed.
Yeah.
So now you have to wear something to protect your eyes, everything that you do. And they go through people like who are in that setting go through the rest of their life worried. They're always worried about something happening to their good eye.
Yeah.
And I have to talk to the parents. You have to wear protective glasses, even if there's no prescription in it, because we can't let something happen to the good eye. You can play sports, but you're not going to box. You're not, I'm not letting you get hit in the eye as you. And you can play baseball, but I don't want you with protective goggles on because I don't want you injured. So what happens if somebody comes to me and they're 40 years old? I have this conversation with them and I say, do you want to try? Go for it. Let's try. And we know if someone who's 40 years old, God forbid, loses their good eye, up to a third of them will have an increase in their vision of at least a line and sometimes 3 or 4 lines on the eye chart. So that's the ultimate form of patching, unfortunately. But no one's going to ever patch that much at age 40 and put themselves into darkness or whatever. So it becomes a problem. So now let's we'll flip your question and not say the age, but let's say a child with an abnormal eye in one eye. They're not. There's an old saying: they're not blind until they're patched and still blind. So how can you recover vision? Well, you put the patch on and their behavior changes, right? They go into themselves and their vision's not getting better. At what point is this no longer medical treatment to try and enhance their life? And does it turn into torture? At what have we changed their life so that they're no longer able to get better vision and they're not interacting and all we're doing is messing with them? And so that's a conversation that, we talk to the parents, how long are they wearing the patch? Generally 3 cycles of patching where they've gone for, depending upon their age, a cycle could be anywhere from a couple of weeks to a few months, and they're not getting better. And they're doing everything they can. They're wearing glasses. They've been corrected. You got to sit down at some point. And I'm late at this. I'll have that conversation with the parents. So I go, look, it's someday we're going to have that conversation. Your child's not getting better. I do not want to be the one who's been torturing your child. We're not there yet. At some point it'll come up. And then the parents and I will have that slowly get to that point where you say the vision's not going to get better. And it's a really hard conversation to have. And it breaks my heart. And I hate having it. And I probably go longer than I should in those conversations because I'm trying to squeeze out whatever vision I can. And I want to make any neural connections I can because I'm leaving the opening for the future. That maybe one day we'll have stem cells that will improve that retina. Maybe one day using dichoptic treatment, 2-eyed video games, which we're now using, work done by Eileen Birch and others, Hess in Canada, and a group in England has been doing it, Alexander Foss. But at some point, maybe there'll be a medicine that works. I tried a study of hypnosis once to try and say, wait, maybe we can hypnotize and change the plasticity of the brain, right? If they can regress people, maybe we can regress them to an amblyopic stage where they would be plastic again. And I worked with a family doing that to try that. It kind of worked. I don't know. So, but I mean, I try and leave that open for the future that maybe one day that science will progress. And look, we have gene therapy and all these other things. So there are people who are trying to grow an eye. There's all sorts of stuff that's going on that's really exciting to me. So, I try and leave that open. So there's that young age when you have to stop, but also there's that older age when why not try?
Yeah.
So if someone's tried and failed and now they're 14, I open the door to revisiting it hesitantly, but I always open that door and have that conversation so that maybe they didn't try as hard as they could. Maybe there's still an opportunity. But if they've never tried, I certainly had that conversation, and I optimistically, with my bright-eyed, bushy-tailed way, let's try, and I cheerlead them as much as I can to try it, to see if we can't recover some vision. That was a really long answer to your question.
But thank you. Yeah, because I mean, I'm interested in this because I'm becoming an occupational therapist, and I'm looking to create a program for people with low vision. And it comes from a personal place, like it does you. My sister has amblyopia, and I appreciate so much that you aren't seeing this just from like an anatomical point of view, that it's an emotional issue. And talking to kids like that is so important, because my parents didn't know it, but I knew it, that when we were in kindergarten, my sister would take her eye patch off when she'd go to class. She didn't like wearing it. So there's.
And that's why, right? For some kids, we use Atropine Drops because it's visible. Like the little kids, you can usually get, as long as they're still home, you can usually get a patch on. But when you get older, the drop is huge.
She would take it right off. We'd walk out of the car and she would just pull that eye patch off. She did not want to wear that. So
wearing the eye patch affected her childhood, and
you
just
like
raised
you were saying,
a secondary issue. It didn't just affect her childhood, right? It affected your childhood. It affected your parents. It affected all the people in the family. So imagine now a child who's got a congenital cataract, and they have surgery, and the parents are always going to the eye doctor. Now they have glaucoma, and they're getting a secondary lens implant, and they're wearing a patch, and the whole family is looking at that kid's second eye, which isn't even the major eye that they're using to function. And every time they make that kid patch, they're taking away vision to try and improve the vision in this eye. And the other children in the family are like, "Are you kidding me? Hello, I'm here," So you have to take that seriously. I tell every family, the doctor has the easy job. All right? It's the family, the parents, and everybody else that has the hard job. You get me all round up. This is really important stuff that we're talking about, and it doesn't get spoken about enough. So I can't thank you enough for bringing it up.
Yeah, well, thank you. If I know that we need to stop talking, but if there's any way I could talk to you outside of this presentation.
I'm here every day. I'm happy to take emails and all that kind of stuff. I this is what I do. It's what I love. And anybody else who wants to help, I'm excited about it.
Thank you. Okay.
And before I forget, Vicki and Bradley and Wanda, everybody from the Braille Institute, thank you so much for putting this together and walking me through how to use this. I appreciate you and all your efforts every day, but especially today for me, I appreciate that. But I hope it didn't take you away from your regular job helping people. And you guys are just fabulous. So thank you so much.
Thank you. And thank you, Dr. Granet. Words aren't enough, and I'm sorry for bugging you with tens of thousands of emails back and forth. But on behalf of Braille Institute, we'd like to extend our deepest gratitude for your amazing presentation and for taking time out of your busy day, not just for us, but sharing with your insight with our patrons, our students, and our staff, who all have learned a great deal today. So, and you've brought me to tears a couple times today, so shame on you.
Sorry, I didn't mean to.